Okay, so I'm in the thumb. I make my way to the subclavian vein, which goes into the superior vena cava, which goes where?
To the right atrium.
Okay, and then I'm going to go through what structure?
Through the tricuspid valve.
Okay, to where?
To the right ventricle.
Okay. Other people chime in. Don't let George do all the work.
And then it goes through the pulmonary valve.
Okay, then through the pulmonary valve into a blood vessel.
The pulmonary artery.
Okay. What's the definition of a pulmonary, or what's the definition of an artery?
An artery carries oxygenated blood, but for this one, it's the only artery that carries deoxygenated blood.
Okay, so that's the rules, but what's the definition of an artery?
Oh, it goes away.
Away from where?
From the heart.
Okay, good.
Yeah.
Arteries transport blood away from the heart. And then the rules are they always carry deoxygenated blood. I'm sorry, oxygenated blood with one exception, the pulmonary artery. All right, so pulmonary artery goes to where? Actually, arteries.
They go to the lungs.
Okay, into the lungs. And then the pulmonary artery becomes what?
Oxygenated.
What kind of blood vessel? No, not yet. No, that's the type of blood. What kind of blood vessel does the pulmonary artery become?
Pulmonary vein.
No, not yet. Here's a hint. Little artery.
Arterial.
An arterial. Okay, so the arterial goes into what? The arterial goes to what?
Arteries.
No?
To a venule.
No, not yet.
To the capillaries.
To the capillaries. Okay. And then that's where the exchange of gases occurs, right? The diffusion. And then it comes out of the capillaries. And it goes into what?
To the venules.
To the venules. And then?
And to the veins.
To the veins.
Okay. And so from the lungs, it's gone to which vein?
Pulmonary vein.
Pulmonary vein.
The pulmonary vein. What's the definition of a vein?
Carries deoxygenated blood.
Carries blood back to the heart.
Okay. Yeah, it carries blood. They carry blood to the heart. Now, with that vein, what's the rule?
It's the only vein that has O2.
No, just with vein in it. Vein in
Carry
general.
Carry
blood toward the heart.
Yeah, they carry deoxygenated blood right to the heart, with one exception, and that is the
pulmonary vein.
Pulmonary vein. All right. So the pulmonary vein drops blood off where?
To the left ventricle. I mean atrium.
The left atrium. And then goes through which structure?
The mitral.
Mitral valve.
The mitral valve, also known as the
bicuspid.
The bicuspid valve. All right, so it goes through the mitral valve into what?
Into the
Left ventricle.
left
Bless you. Into the left ventricle.
ventricle, yeah.
Okay, left ventricle goes to where?
Aortic valve.
Into, okay, goes through the aortic valve.
Yeah.
Into where?
The aorta.
The aorta. Okay, so now it's going through the aorta and it goes into which artery?
Mm. To the body.
Well, it's, yeah, the aorta, it's going to send blood to the rest of the body. There's
Yeah.
already some diversion, subclavia and the carotid. No, eventually you consider carotid. I can't remember the other two, but there's three branches that it diverts it to. All right, so aorta goes down the chest, so it's the thoracic aorta,
Thoracic aorta, yeah.
and then it becomes what aorta or artery? All right, it's actually, yeah, it's still an aorta. What aorta is next? So trace it with your finger on yourself. So the heart up, out, the thoracic aorta, and then it keeps going. And then what's the next major aorta or blood vessel?
Femoral.
No, not yet.
No. Um,
Mm-hmm.
You couldn't see me tapping it.
Your abdominal or aorta.
Yes, abdominal aorta. And then goes to what? It's already been said.
femoral.
Femoral
Femoral what?
artery.
The femoral artery.
Artery.
Okay. And then femoral artery to where?
Tibial artery.
Nope. We went right past that.
The popliteal artery.
There you go. And aren't we where we wanted to go?
The what?
Yes.
Did we destination?
No.
The
Yeah.
area behind the left knee?
Yes.
Yay, ta-da. What a review, huh?
Yeah.
Yep.
So we've already covered this stuff, right?
Yes.
Yeah.
Yeah. We've talked about arteries, we've talked about veins, we've talked about the structures. We know about the pump, we know about the pipes, we know about the fluid. Correct?
Yes.
Okay.
Yeah.
So Valeria and Sequoia are caring for Bart Frey. I will say Gerardo. So they're caring for Gerardo, a 62-year-old man with a history of angina. Angina is just like coronary artery spasms that reduce the blood flow to the heart muscle. It's not a heart attack, but it's a reduction of blood flow. So Mr. Herrera experienced an onset of a heavy pressure in the center of his chest, radiating to his left shoulder, and accompanied by profuse sweating. Valeria's general impression is of an alert but anxious patient who appears pale and diaphoretic whose facial expression indicates distress. So I just told you what the underlying process of angina is, right? Which is,
Spasms
yeah, of
of the heart, or I mean, the blood, or
yeah, the blood supply, the coronary arteries. So is the patient's presentation consistent with angina, or do you suspect something else?
I suspect something else.
Okay. What additional information do Valeria and Sequoia need as they begin patient care?
Patient history of possible heart attack or stroke.
Okay. What else?
Well, does it count as the patient history of a heart stent or
Yeah,
open heart surgery?
yeah. And he has no zipper. That's open heart surgery scar. Call it a zipper because it looks like a zipper.
Yeah. Mm.
What else?
We would probably take vital signs.
Okay.
If he takes any medication for it.
Probably takes nitro.
Okay. How many did he take in the last hour, or has he taken any at all?
Okay. What else with that?
If he hasn't taken any, can we ask him to administrate it? Like help him administer?
Administer. Administrate is like when you're doing administrative work.
Yeah. Sorry,
Administers to give. How about, did he experience any relief with that nitro?
Yeah.
And you're right about vital signs. Before we give nitro, we have to make sure our blood pressure is okay to give. Anybody know what the systolic pressure has to be at?
90.
90. Yep. All right. What else? A little bit more on the OPQRST. Onset, provocation, quality, radiation, severity, and time.
Mhm.
Because with that medical history, and don't forget to ask the OPQRST, the onset. What were you doing when the pain came on?
Okay.
And that could also be provocation. What were you doing when it came on? Anything make it better or worse? Okay. All right, in your book, you have that picture of the coronary arteries. I can't tell you what figure it is because it's not showing me.
You mean the major artery?
No. Keep going. Coronary arteries.
I think it's 527.
Yeah, 527.
All right. So you see how the aorta pops up and you have those two branches off the aorta?
Yes.
It shows the right coronary artery and the left coronary artery.
Yeah.
Yeah.
So where those coronary arteries meet up with the aorta, that opening there, that's the coronary sinuses. So remember that question that talked about if the carotid pulse is barely palpable, what organ is still getting perfused or are still getting perfused? So how much pressure do you think that heart has to push or has to create to get blood into those coronary sinuses?
A lot.
A lot of pressure.
No.
Very,
Well,
very little.
Yeah, it's not going to be as much as trying to push it up to the brain working against gravity.
oh yeah, true.
All right. So that's where the coronary arteries start, and they work their way down. And so you see, for example, the anterior descending branch, the left anterior
Left
descending.
anterior descending.
Yeah. A heart attack on that, they call it a widowmaker because it's affecting the left ventricle. And why is the left ventricle important? Because that's what pumps blood to the rest of the body. So if you have damage to the left ventricle, you have failure
That's it.
of the heart muscle, and it could lead to things like pulmonary edema.
Yeah.
It could lead to death.
Mm-hmm.
Okay. So that's why they call it a widowmaker, because of it leading to
It
death.
makes the widowmaker.
This is so freaking slow. All this stuff. You know what? Let's take our break now. I'll be back at 10 o'clock. I'm going to try to reboot my computer. Maybe it's going to speed up. It's just driving me absolutely nuts. Okay.
All right, sounds good.
So be back at 10.
All right.
All right.
What are you doing?
Making the bed.
Is that you make the bed?
Yes, I didn't have like
I'm just gonna go to over and listen to closet.
all of this.
Why?
Honestly.
And that, oh, this one goes in the closet. You're still in class?
Yeah, but it's muted. He hasn't came back yet. Luis. Yeah.
What is he doing?
You ain't muted, man.
Thanks, bro.
No problem, man.
right, can you guys hear me?
Yes, Lou.
Yeah.
Okay.
Yeah.
So far it's faster, so we'll see exactly how fast. My dog is so lazy. It must be nice. Oh yeah, it's going a lot faster.
I was gonna say, you want to compare laziness?
What was that?
You want to compare laziness?
Yeah. You know, it was funny. I was checking out my timesheet yesterday because I have to approve my clinical coordinator's timesheet. So I looked at my hours and it had like 144 hours. And I'm like, wait a second, I didn't do 144 hours or 140 something hours. And then I looked and they gave me for Friday and Saturday 2 weeks ago, they gave me 20 hours of hazard pay or, you know, stay at home for coronavirus pay. Like, wait a second, how am I getting 20 hours? But I'm salary, so it really doesn't matter. It's not like I got 60 hours of time and a half.
Oh, geez.
I wish, but no, I didn't.
Hey, more money for in your bank account.
Yeah,
Yeah.
I'm able to save up some money now.
Did they pass the law or the bill for the stimulus check for the second one?
No,
I don't think they have yet.
no. The House of Representatives did, but because there's so many other things, pet projects,
Yeah.
that the Senate's like, oh, hell no, we're not going to do that. And not just because I'm a Republican, but I agree with give the economy a chance to try and recover.
Yeah.
You know, don't just
Oh,
keep
yeah.
giving money away because it's not free money. You know, they're taking out loans to be able to pay all that stuff.
Oh, yeah. And, it's
And
gonna
this is over a $3 trillion bill. So they would have to take out more loans in order to be able to pay that. And so that's not a very good thing to do, to put other generations in debt. And the biggest issue right now is the extra $600. People are making more money on unemployment than they were actually working. So a lot of people don't want to go back to work. And that's a bad thing. I mean, I can get more political, but I won't. But, you know, you got to let the economy get a chance to recuperate on its own. So, all right. So here's where I was talking about where the coronary arteries start off. And so you have the coronary sinuses right in there. That's going to feed these arteries. And so when we start having issues is because, let me choose a different color. So let's talk about the left anterior descending coronary artery, the LAD. So we have a blockage. See, that's why I need a pen. We have a blockage right there. The blood flow stops right there, right? So what's happening to the area, to this area right in here? It's not getting fed. We'll actually go this area here. So this area in here is not getting fed. So what's the heart muscle going to do?
It's gonna die.
Yeah,
It'll start
it's going
dying off.
to die because it's not getting perfused. That's what a heart attack is, where the heart muscle, and we actually call it a myocardial infarction, where the heart muscle dies. And so now this area is no longer functioning. So it affects what we call the ejection fraction. And you don't need to know that. I'm just giving you extra information, which is the force of the ejection, the amount of the ejection. So with the damage, what just happened to that ejection fraction? Went down. So not all the blood is getting pumped out. And thus you have pulmonary edema. And that's exactly what happened to my dad. He had actually a 99% occlusion on this artery. And luckily it was a non-STEMI. If it had been a STEMI, he would have died right there. But it was a non-STEMI, but it was too much. Plus his renal failure, they fucked him up. They killed him. So that led to his rapid death. Within 2 months of his heart attack. Yeah, just a little over 2 months, like 2 months and a day or something like that. 2 months and 2 days, something like that. He passed away. So, but anyway. So we've talked about the blood. So this is what's happening, so you understand. So here's a normal lumen, okay? You have a nice clear tube for the blood to go through. But you see how there's some damage right here. You have the plaque starting to build up. And as it goes, it gets bigger and bigger. So the more doubles animal style that you eat, the more fat you deposit within the arterial walls. And this is what arteriosclerosis is where there's the plaque buildup within the arterial wall. Where atherosclerosis is actually within, we call it the tunica. Those are the layers of the arteries, tunicas. Tunica intima, tunica media, tunica, I think externa. But there's three layers to an artery. And so that's building up. Let me show you my pen. That's building up within here. It's not on the, well, literally on the inside, within the lumen, this area in here. It's actually within the wall in here, and it's pushing, it's doing the same thing. This time, though, this is extended and it's pushing it out. So it's creating this narrower passageway. So what happens to the blood flow through that diminished lumen opening?
Decreased volume.
Yeah, decreased volume is going through. And what happens, and I think I've shown you guys this before. So if you have the buildup, right? That's why I need a pen. Blood flow is going through, but not all of it is going through. Some of it stays here, and it creates an eddy. Kind of like a riptide. So some of this blood is just swirling right here. And what happens to the blood when it becomes stagnant?
Start building up.
It starts clotting up. Yeah. So what just happened to the blood flow?
Ceased.
It diminished.
It stops.
Yeah. Yeah. And so now the heart muscle is going to go through stages, through ischemia, and then injury, and finally infarct. So ischemia is decreased blood flow to the heart muscle. Injuries, when there's some injury starting to occur to the heart muscle, and infarction is where the heart muscle dies. Now, the chest pain that people feel. What happens when that muscle starts to get injured and starts to die is that it releases a substance called substance P, P as in Paul. And that substance irritates the tissue. So the pain is going to be around where the MI is occurring because substance is being released to that area. So when the person's having like left arm pain, it's on the left side of the heart. If it starts going up to the jaw, then it's more like anterior septal. It's kind of going up into the jaw area. Now, another one that you guys got to be very, very careful of is what we call an inferior MI, or a myocardial infarction, a heart attack, but start calling it an MI or myocardial infarction. And it's going towards the bottom of the heart, over towards the diaphragm. So those patients describe it like a indigestion type of pain. So if you have a patient that's complaining of indigestion and they fit the mold of having a heart attack, you know, the 60, 70-year-old guy that's out of shape, balding, wears glasses. I'm only 48, so don't even think it's me. Just making sure, smart Alex. That's the typical, that's the like stereotypical patient that's going to be having a heart attack. But young guys, I remember going on a 30-something-year-old, I think he was a chiropractor, but this guy was fit. He had home gym equipment. There's pictures of him rock climbing and all this other stuff. And guess what? He had a heart attack and he died. Healthy people also have heart attacks. So just because you eat like crap and you don't exercise, you sit all day long like we do right now, doesn't mean that we're susceptible to a heart attack. Everybody is. George is, Paul is, everybody is, okay? My dad never had any heart issues. All of a sudden, he has this heart attack. Why? He's eating healthy. I mean, he'd work out, not like that, but he'd stay busy around the yard and stuff. So he was always doing physical activity. And he still had a heart attack. So, a real quick story on that inferior MI. I was actually doing hospital clinicals for paramedic school. And ambulance calls in. It's 2 EMTs. Ambulance calls in. They say, we have a patient that was complaining of indigestion pain. Paramedics saw him. They released him. He's currently unresponsive. We have CPR in progress. So we get to work. We go into the room. They bring him in. I got to defibrillate the guy, which was kind of cool. Back then, we did it hands-on. So we had the paddles. But actually, we put the orange pads on him and then the paddles on the chest. And clear, I'm clear, clear, we're all clear. Bzz, zap, right? Needless to say, the guy died. Well, the nurse that I was assigned to, she was livid because the EMTs brought in this patient. The reason being is the EMT should not have brought that patient. The paramedic should have, because and I asked her, or I think I mentioned it to her because I learned it and somehow it stuck in my head. I'm like, was it inferior MI? She's like, yeah. And then when I told one of my paramedic school instructors and I told her that story and she's like, what did you think it was? I'm like, inferior MI. She's like, exactly. Because it presents like indigestion. Okay. Now, what you guys have to understand about heart attacks, I told you about the typical, right? Elderly male, balding, out of shape, has a dog. Again, that's not me. That you would expect them to be having a heart attack. Okay, that's typical. The chest pain. Oh, you know, I know you guys don't watch Sanford and Sons, but oh, Martha, here I come. It's the big one. Watch out. Here I come, baby. Try to imitate Red Fox.
Old Mabel.
What was that?
It's Old Mabel. Old Mabel, I'm coming. Here I come.
Oh, was it Mabel?
Yeah.
You watch Sanford and Sons?
Yeah.
Damn. Sequoia, you're like born in the wrong era.
Well, I wasn't really
You're
allowed
so
to.
young. Huh?
I wasn't really allowed to watch like certain things. It was whatever my mom put on, especially like growing up. Like I didn't listen to hip hop or rap or any of that. It was always country or oldies. That was it.
Yeah. How old are you? Like 22, 23?
28. Gonna be 29.
You don't look it.
Oh, I feel it.
Yeah, I feel my 48 years, let me tell you. So anyway, so now let's pick on women, shall we, guys?
Yep.
Ladies,
Yeah, why not?
you guys are so delicate. Oh my gosh, I don't sweat. I glisten. Right? But women, you have to be difficult and you have to be different, don't you?
Yeah. Just
All the other ladies are staying quiet. The thing about women is they are going to present differently. In other words, don't expect them to be like, oh, Mabel, here I come, baby. No. Women are going to present differently. They're not going to have that, for the most part, they're not going to have that crushing chest pain. what they're gonna do is they might feel tired, they might feel sick, they might feel run down, but they're not gonna be presenting with that crushing chest pain. So be very, very careful with that. The other thing too is people with some chronic conditions like diabetics because of the nerves. Like right now, my calves are numb.
Is it true that women are more likely to have like a heart attack earlier than like men?
That men are more likely to have it than women, or women more likely to
that-
have it than men?
That women are more likely to have it than men.
No, men are more likely to have a heart attack, or at a younger age. You're talking about younger age?
Yeah, like younger age.
It kind of depends. So we've been talking how about you ladies are special, right? You're unique, right?
Yeah.
Well, here's another unique thing about you. Until you reach menopause, you're pretty much saved from a heart attack.
Yeah.
Now, there are ways where you don't, like if you have a hysterectomy, or if you're like really, really overweight. Like any of you ladies in this class, if you were to tell me you're having chest pain, I would not be saying you're having a heart attack. I would probably be asking about any type of stressors in your life right now. Anything causing you to be anxious besides school. I know school's anxious anyway or stressful, but is there anything else going in your life? Because it's usually an anxiety attack. Now I'm speaking from experience. Remember, I've been doing this a long time. And in my experience, when a woman of childbearing age is having chest pain, it is not a cardiac event. It is usually a behavioral event, a panic attack, an anxiety attack. Okay? Because about every 28 days, you get an oil change. That's the way my instructor in paramedic school put it. It's like they get an oil change.
Whether to laugh or make a smart remark for that.
Let's hear it. Come on.
No, I'm good. I'll keep it to myself.
Was remember, I'm just repeating what I was taught.
Okay, so like, have you know that thing that like hypoplastic left heart thing?
Uh-huh.
Okay, so I had that, and I get like random chest pains sometimes. Am I dying?
No.
No. All right.
I mean, we're all dying, but no,
Oh, yeah,
chest
but
pain could be something else. I mean, have you had an EKG? Have you had blood work to see how your heart is? You had an echo?
A while.
You can also
So-
be your blood count might be low.
Yeah. But no, usually it's not cardiac related. Now, if you're like 350, 400, 500 pounds, then you're a woman and you're having chest pain. Oh yeah, I'm going to think about a cardiac event. But any of you ladies, no, I'm not going to say it's a cardiac event. I'm going to say it's something else. Or maybe you were working out and you worked out too much. You're benching 200 pounds this morning and now your chest is sore. So,
Would that just be muscle, or would that be?
yeah,
Your-
muscular.
Okay.
Muscular. Okay. So here's what you guys have to remember as EMTs, though. Again, even though I told you my experience and what I know based on experience, as EMTs, if a patient is having chest pain, we need to treat it like a cardiac event until it's proven otherwise. As EMTs, we can't prove it otherwise. So just treat it like a cardiac event. It's better to be safe than sorry. Okay? It's better to be safe than sorry. Got it?
Yes, sir.
All right. Like a cardiac event. All right, we talked about that. no blood pressure, inadequate circulation, we've already talked about. All right, we've been talking about acute coronary syndrome. Okay. So one thing to remember with acute coronary syndrome is time is muscle. The more time passes, the more muscle is damaged.
Cardio what?
Huh?
Cardio what?
I said for acute coronary syndrome,
Oh,
the more time passes, the more cardiac muscle is damaged. So we talked about atherosclerosis, and then arteriosclerosis also, that's where it's within within the not the lumen, within the walls of the arteries. Okay. All right. So we're talking about angina. And angina, like I said, it's a coronary artery spasm that's reducing blood flow to the heart. However, it almost presents just like a heart attack. And actually, I need to do something here. One of the ways to differentiate a heart attack from angina is that, number one, angina is usually comes on with exertion. What I'm going to put up right now is a handout. It's a chest pain table. All right, so angina pain comes on upon exertion, and it's relieved with stress. Uploading, it's up. Quit yawning in my ear. All right, let me reduce the size on here. So this has a couple other things, okay? So it has dissecting aneurysm, pulmonary embolism, pericarditis, pleurisy, esophagitis, and hyperventilation syndrome. So angina, like I said, pain or provocation, exertion, or emotional upset, where an MI could be non-provoked. Just sitting on the couch, all of a sudden, excuse me, all of a sudden that chest pain comes on. But it also could be upon exertion or emotional upset. Quality. They're both about the same. It feels like a pressure on the chest, like they're somebody squeezing their heart. The radiation, it could go to the same places: the jaw, the shoulder, the back, and it doesn't have to be the left shoulder. It could also go on the right, but that's rare. Okay, but it can go to the right side as well. Severity, mild to severe with a heart attack, it becomes severe. Now, another thing with severity, a patient with angina has their own nitroglycerin prescribed to them. So if usually with angina, if they take their own nitro, their pain level is going to go down. And even if we help them with nitro or if we administer nitro and the pain goes down, it's probably not an MI. If it stays constant, even with nitro, then it's probably is a heart attack. Okay. And then again, with angina, as far as time, it usually subsides within 30 minutes. If it doesn't subside within 30 minutes, then it's probably an MI. Okay. So I uploaded that table for you. It's on the files right above your grades. Want to print it out, have it, learn it? Questions, comments?
No, sir.
So would it always follow this way, or?
For the most part, but you got to remember that patients don't take the same class we do.
Yeah.
You know, I wish we can give them a copy of the book and say, you got to do this way because this is where I learned. But we can't. But the general rules is the pain more or less than 30 minutes, relieved with rest versus not relieved with rest. No relief with nitro. Those are the big indicators. But again, you're still treating it like a cardiac event. So you're not going to really make the difference and say, oh, you're not having a heart attack. There still has to be a 12 lead done. They still have to go to the hospital. They still have to get troponin levels done. So there's still stuff that's going to be needing to get done. But as EMTs, there's not a lot of stuff we could do except treat it like a cardiac event. Now, the big thing with MI, though, is, or any type of chest pain, is the amount of oxygen, okay? And I think that was on the exam. When you have a patient, and in this particular case, it's chest pain, we need to put them on the pulse ox and make sure that the pulse ox is reading well enough. If they're at 94% or less, then we put them on 2 to 4 liters via nasal cannula. Usually start off with 2, see what happens. Because the goal is that we want to make sure that their pulse ox is at least 95% with that oxygen. As long as it's above 95% or better, we're good. Okay, it doesn't have to hit 100. As long as it hits 95, we're good. Okay. So there's a little bit of blockage, a spasm of the blood flow into further areas. So you see this clotted area? That's heart muscle damage. So regardless of angina or an MI, you're going to treat it the same. Okay. The other thing that we might be able to do is aspirin. It's 160 to 325, but the rule of thumb is you give them 4 baby aspirin. Why is it baby aspirin?
It's a low dose.
Well, you're still giving them 324 milligrams of aspirin, so that's a normal adult dose.
Because it distributes faster?
Nope. It still has to go through the stomach, still has to be absorbed, still has to be metabolized in the liver, third pass metabolism.
Isn't it like help with the clots or something? Like with the blockage flow?
Both the children's aspirin and regular adult aspirin is going to do the same thing.
Well, it stops the formation of clots, though.
Yeah, aspirin's going to do that regardless of whether it's baby aspirin or adult aspirin. Why do we give them baby aspirin? Because it's chewable. Adult aspirin isn't. So the children's aspirin comes in 81 milligrams. So 81 times 4 equals?
32.
81 times 4.
Oh, yeah, 224. I'm sorry. I'm sorry. I'm thinking of 80 times.
324.
Yeah.
Yeah, 324. Kind of talked about it, MI. So, no, you notice how pretty much it's the same, although an AD, having it available in case they go into cardiac arrest. Remember, there is a difference between cardiac arrest and heart attack. Cardiac arrest is where the heart stops. There's no pumping going on. Whereas a heart attack or an MI, myocardial infarction, up here, or an AMI, acute myocardial infarction, okay, the heart is still pumping. It's just, it's been damaged. So there's still pumping going on. Okay? All right. So I didn't pick that one. No, I don't want that one either. Okay. So you guys the two of you. See Valeria and Kevin. Valeria and Kevin, you guys are a team. I know Valeria's here. Kevin, where are you? Don't tell me you're in the shitter. I mean the bathroom. Pinch it off. You got a call.
I'm here, sir.
All right. See, he pinched it off because he got a call. That's how we mess with rookies or probies also. While they're in the bathroom, we'll slam or we'll bang on the door and be like, hurry up, we got a call, pinch it off. And they come running out trying to zip up their pants and put on their belt and shit, and then we start laughing. No, that's not hazing. No, that's not hazing. Although the funniest one that happened to one of our captains, he wakes up in the middle of the night and he goes to take a pee. And he starts peeing. All of a sudden, he starts splashing his leg. He's like, what the f? Right? They had put saran wrap on the toilet.
No.
I tell you, and that was a captain they did it to. All right. So, Valeria, there you are. Hi, Valeria.
Hi.
Are you ready to run a call with Kevin?
Yeah.
Come on, say yes. Let's do it. We got this. All right. So, Rescue 13, respond to 666 Witchy Way for a report of a male with chest pain. So, who's our lead here, Valeria or Kevin? All right, press, pick a lead, Kevin or Valeria.
Kevin.
All right, Kevin, let's hear it. Kevin,
Yes, sir.
let's hear it. What are you gonna do? You respond, you arrive at scene, and then what? Come on, Kevin, you've run calls before. What do you do when you get there? And don't say wait for medics to get there. Because I know you're an ECA, right?
No.
You didn't test?
Nah, I never passed it.
All right, Kevin.
I
Well,
have
you
one.
still took my
I have-
class, so you should know what to
Yeah.
do. So what do you do? And we've gone over patient assessment, so let's go back to that. So you're seeing what's the very first thing you do?
Just see, like the scene size up and all that.
All right. So what do you want to know about the scene size up?
Is it safe for you to get out of your vehicle, or is it safe for you to enter the home?
Okay. So as you approach the house, so there was nothing there for you as far as, como se dice, any hazards. So you get out of your vehicle, you start approaching the house. And as you approach the house, you notice a large dog, big ass Rottweiler. And he doesn't like guys. Because he has his eye on this cute little this cute little Chihuahua down the street. Can you imagine that? A Rottweiler and a Chihuahua going at it.
Chihuahua? I've never seen a cute Chihuahua yet.
Haven't you seen Beverly Hills Chihuahua?
Yeah, but they're not cute.
Well, they try. Or didn't you see Legally Blonde? But
Yeah.
Bruiser?
Yeah.
That ended up being a gay dog. There's nothing wrong with being gay, so.
No, I have gay friends.
Yeah, I do too. My best friend, she's gay.
I think
And I have a cousin that's gay, so I really, to me, to each their own. I have no problem with it. All right, so you have that large dog in the front yard. What else? That's a Chihuahua upset. My dog woke up.
He's on the floor asleep.
No, mine woke up all of a sudden. She's looking at me like, what the hell?
Come on. It's like what?
Mm-hmm. There's mine over there. Can you see that?
Slowly looks at you.
Yeah. See that? It's a mixed Maltese and poodle.
A multi-poo?
Yep. So that's the Rottweiler barking at Kevin. And then sees Valeria and it's like, Come on, we're all waiting. So what do you do next? That dog is.
Well, that would be unsafe for me.
Okay, so what are you gonna do?
Slowly walk away.
And?
Go ahead and tell dispatch that I wasn't able to enter due to, I don't know, a dog.
Well, how about looking to see if there's any bystanders?
Or that, or I could also see if there's people inside the home and be like, hey, can you hold the dog or something?
There you go. There's a wife right there. And so she grabs the dog and secures the dog. So done. What else? What do you think, Valeria? What's next?
We go inside the house or wherever the patient is at.
Okay. So you see the one patient, he's sitting in a chair in the living room. Mechanism doesn't appear to be trauma, especially chest pain, but we'll just turn that in a little bit. Additional resources, what do you think? Do you need any additional resources?
ALS maybe?
Okay, good. And the need for extrication or C-spine, is there any indication that you might need that?
No.
No, okay. All right, Kevin, so let's go back to you. So what's next?
Would it be my primary assessment?
Okay, so what do you want to know first?
Would it be like the ABCs.
Before we get to the ABCs.
Would it have to be my um?
Want to help him out, Valeria?
Would it be if like it has to be like a load and go or stay in play?
Nope, that's the one in the 331. Somebody want to help them? Otherwise, it's going to be 12 o'clock.
You're in general impression.
All right, general
And
impression.
then your ABCs.
Hold on, let me answer you one at a time.
Oh, brother.
Guys, don't forget to write down the information so you know what to do. All right, so general impression is, it's a middle-aged male in minimal distress. So there's nothing bugging you about him. You do see that he's kind of suffering a little bit of pain. What else?
Level of consciousness.
Okay. Level of consciousness, he's alert, he's tracking you.
Then now you're
Skin color or skin tone.
Nope, we're not there yet.
His age, sex, position, and environment. Which one?
No, that's general impression. And remember, what I told you guys, if you can't figure out that this is a guy, then there's something else wrong. So remember, the general impression is anything about the patient that's bugging you. And then after that, like Sequoia said, is the level of consciousness. And after that, what is it?
Chief complaint.
Chief complaint. So how do you establish the chief complaint?
Asking the patient.
Okay, so somebody talk to the patient.
What seems to be the problem today?
What was that?
Or my name is Aaron. What is your name first, and then what seems to be the problem today?
All right, give the patient a chance to answer. My name is Henry.
Yeah.
Okay, what's next? Aren't you guys gonna do something? Man, my chest hurts. Patients will do that to you. If you just stand there with your thumb up your butt, they'll be like, what the hell are you doing here? Yeah. Somebody, what's next?
Okay, Henry, how long ago did your chest start hurting?
It started, sorry, about 20 minutes ago.
What were you doing while?
Just sitting here watching TV.
Is it radiating anywhere?
Have you taken?
I'm sorry. It's actually been going on for the last 45 minutes, and no, it doesn't go anywhere.
Have you
I
taken
just feel like I have indigestion.
Have you taken anything for the pain?
So, and it's good that you're asking questions, but don't forget to either you or your partner start checking the ABCs, get vital signs. So what was your question again, Sequoia?
Like you were gonna ask them like how have you taken anything for their pain?
Mm-mm. No, I haven't.
And then you asked about history. Have you had any?
Okay, so I have a history of high blood pressure, and I have holes in my stomach.
Like in cancer or just holes?
Holes.
Ulcers?
Yep.
Okay, so
Can we get some vital signs?
Okay, what vitals do you want?
Can we have the respiratory rate, the pulse, the O2, and the blood pressure?
What vital signs did I teach you guys?
blood pressure, respiration, pulse.
The
Oh,
eyes, the dilation,
skin.
whatever. Yeah, skin color, skin tone.
PR bells, pulse, respiration, blood pressure, eyes, lung sounds, level, constant skin signs. You could also throw sugar and pulse ox in there. Or PR bells, pulse ox, respirations, blood pressure, eyes, lung sounds, levels, consciousness, skin signs, and sugars. Okay. So what else? All right. So because you guys told me PR bells, kind of, sort of, but we'll just pretend you did.
Yeah.
We have a blood pressure of 178/92, pulse rate of 104 and regular, respiratory rate of 22. You have skin signs are slightly pale. His sugar is 86. Pulse ox is 90% on room air.
What about his eyes?
Eyes are pearl.
What was his pulse ox?
90%.
90. So you would start rolling.
You gotta administer oxygen for sure.
Yeah.
How much?
15 on rebreather.
No, what did I tell you guys? You want to kill the patient?
True.
You'll give
He's
it
at 90, so everything else.
So we're going to administer oxygen how?
You'll two
Nasal cannula.
Okay. So 2 liters via nasal cannula.
mhm.
All right, what else?
Okay.
You said his blood sugar was 86?
Yep. So, remember yesterday we're talking about OPQRST?
Yeah.
Well, we do OPQRST on 3 types of patients. We do them on chest pain patients, we do them on respiratory distress patients, and we do it on abdominal pain patients. So are we going to do OPQRST history on this one?
Yes.
So you guys already asked a couple of them, but let's just go through it again. So what do you want to ask?
How long has the pain been going on?
It's been going on for the last 45 minutes.
Have you had any recent history of stroke or heart attack?
No.
What causes it to? What causes the pain? Or how would you say?
So remember, onset,
Yeah.
45 minutes ago, provocation. What were you doing when the pain started?
You were
I was
sitting
watching
down.
TV. I was sitting on my recliner here watching TV. Quality, how would you describe the pain? Oh, it feels like an indigestion type pain.
Can you do like a 1 to 10 pain?
Yeah, that's the S, severity.
Okay.
So he also says, oh, it feels like someone's hugging me really hard. Radiation, does the pain go anywhere? No, it just stays around my stomach. All right, with one finger, can you point to where it hurts? And he points to like his diaphragm area. So it's epigastric pain. Severity on a scale of 1 to 10, 10 being the worst pain you've ever felt. What number would you put it at? Oh man, it's pretty bad. I'd give it like an 8. Okay, so what next?
Anybody?
Take a sample.
Okay. Well, we kind of already did that with OPQRST. What else?
What meds is he taking? Or allergies? Is he allergic to anything?
Okay, which one do you want? Meds or allergies?
Allergies.
Allergies. I don't have any.
Okay.
And current medications?
I take Prilosec and I take something like Pistolic or something like that.
It's a blood pressure med, right?
Yes.
Okay. Your medical history?
Okay, so guys, don't be robots. Remember I was telling you guys that? So just talk to your patient. Talk to them normal. So how would you talk to the patient normally? Without using big fancy words.
Do you have any medical problems?
Okay. Yeah, I have high blood pressure. Remember we talked about this? I got high blood pressure and I got holes in my stomach.
Okay, it's okay.
That's all right.
I'm so sorry.
What did you last eat?
Okay. I had breakfast this morning. I was getting ready for lunch, but that's when my pain started. The events leading up to it was what?
He was watching TV.
TV, sitting
Okay.
down.
Sitting down watching TV. Pain started. So what are you thinking about so far?
Possible stroke.
Where are you getting stroke from?
Oh,
Possible heart attack.
sorry.
Man, you just love strokes, don't you? Sophia?
I see all the time, so
Yeah, but one, we're not covering stroke. Two, there's nothing to indicate he has any slurred speech, any facial droop, any arm drift. He's not incontinent. He doesn't have a droopy eye. He has a
Either
sore throat.
MI.
Stable.
Yeah, possible heart attack.
There you go. Possible heart attack. Could it be angina?
Yeah.
But
It
His blood pressure is high.
well, you could have that too with angina.
How old is he again?
55.
Hey, but doesn't he have indigestion, or he feels that?
Yeah, he
Yeah.
feels it like it's an indigestion type of pain.
That would be more of a symptom
Have you taken any nitro for it?
like an inferior MI, right?
I'm sorry. One more time. Not the natural one. The other person I was talking.
Oh, I was saying that wouldn't that be a symptom of like an inferior MI, like the indigestion pain?
Exactly.
Feeling like indigestion pain?
Yeah, and that's why I told you guys that. Well, I didn't know that this was the scenario, but yeah, remember, any type of indigestion, you got to think about you have to think about the possibility of inferior MI. Now, the other thing that I'm going to tell you, and I got to tell you, is your patient is having indigestion type of pain. We are not going to give them nitro. Okay. The reason being is it vasodilates, but what can happen is you could drop their preload. Do we want to drop their preload?
Nope.
No, we don't.
No, if they're already having a heart attack, can't you kill them?
Yeah, it will make things worse. So
Yeah.
this one would not get nitro. This one would not get nitro.
Can we administer aspirin?
Okay, you could do aspirin. Okay, you could do aspirin. Anything else?
Wait, so we would do aspirin even if he has holes in his stomach? Wait, so we would do aspirin even if he has holes in his stomach?
Yeah. Yeah. He takes medicine for it. He takes Prilosec, so he takes medicine. In that case, maybe you'd go to like 162 milligrams of aspirin instead of the 4-3-24. 162 milligrams of aspirin instead of the 4-3-24. Okay. What else do you want to know? Anything else? What else do you want to know? So we done with our secondary? Somebody, yes or no? Oh, Lou, I see your hand up. You know, you have a hand up icon on your menu bar, the thingy. So, yeah, Lou, what's going on? Oh, there's my hand. Yeah, what about reassessment? Because he's having a possible MI, we're going to reassess him every 5 minutes. All right, Lou, good job. All right, what do we want to reassess? Well, I want to reassess my interventions. I want to reassess my primary assessment. I want to reassess my vital signs. Pulse, respiration, blood pressure, eyes, lungs, sounds, level, custom, skin size. All right, good. So, Lou, upon your reassessment, you do have a 5 now on the 10 scale. His BP is 174/90. It went down a little bit. That's how it started. His pulse rate is 104 in regular, and his pulse ox is now 98%, and his respiratory rate is 18 a minute. All right, I would consider continuing transport to the local cardiac care center.
Good job,
See how it
Dave.
works? Huh?
Good job,
See how it
Dave.
works? Thank you. So you guys see how all that works?
Yeah.
You guys You don't sound enthused, Miss Sequoia.
What?
You don't sound that enthused.
Oh no, I was sorry.
So part of doing it this way, and I think I mentioned it to you guys yesterday, is reading ahead and preparing for these discussions. But part of it, we've talked about it before. We know what's happening. Blood flow being affected to the heart. We know what happened. Again, we talked about it yesterday. The body's not getting enough oxygen. That's it's increasing the carbon dioxide level. I know we talked about blockages to the heart. We talked about left ventricular failure for connected to the heart. So we're just adding on a few other things with the heart attack. So coronary syndrome with treatments. The big thing is you have a cardiac patient treated like a cardiac. Until it's proven otherwise, then we can't do it. So on that particular call, once the medics got there and assessed the patient, they found that the patient was in fact having an MI. So, and I've gotten patients that were having chest pain and the EKG didn't show anything. This does not make sense. The lateral in my. Anyway, so questions.
When you were mentioning about doing OPQRST for 3 type of patients, you said it would chest pain, abdominal pain, and what was the last one?
Shortness of breath.
Oh.
All right. All right, so Valeria obtains a history from I forget who it was. What did
Henry.
you say, Brandon? Huh?
Henry.
Oh yeah, Henry. From Henry, has Sequoia conducts a focused physical exam and takes baseline vital signs. Henry's discomfort came on 20 minutes ago while he was riding a stationary bike. So is this provoked?
Could have.
How could it have been provoked?
Because he was exercising on his bike.
So how's that kind of provoked?
So it was provoked.
Mm-hmm.
Sorry.
All right, so next, it was not relieved with rest or after taking a nitroglycerin tablet. So what do you think is going on?
An MI?
A possible MI. Mm-hmm. Because it's not relieved by rest, and it's also not relieved by nitro. He rates the discomfort a 7 on a 10 scale and says the sensation is worse than he normally has with angina. So is it reinforcing our belief?
Yes.
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 Yeah.
All right. His vital signs are pulse of 80, strong and regular, BP of 132 or 84, respirations of 16, and pulse ox of 99%. What do you think?
He's good standing.
Yeah, he seems to be stable. And somebody wants to get in a hurry. So what treatment should be implemented for this patient?
He only took his nitro once, right?
It doesn't say, but yeah, we'll go with that.
I guess since he's good standing, you can help administer another dose, can't you?
Mm-hmm. How do we know we can?
Because he's not saying it's what did you say, indigestion or?
Not with this one. No, it doesn't say where it is.
Oh, you can because his BP isn't under 90.
His systolic PP.
His systolic, yeah.
So are you going to give him more nitro just because you can?
No, no.
Why?
Yes, I would say yes because his pain's not gone away, and he's taken it once.
Well, the night before or the morning before, his wife wanted to have a little bit of happy adult time.
Didn't go well.
Erectile dysfunction medication. Right?
Yep. So just because he took it doesn't mean that he's not taking it. Maybe he forgot because it was his birthday. So that's when you're married. That's about the only time you get it, on your birthday. Maybe.
Or on your anniversary. Maybe.
Yeah, right. We'll just say on your birthday for argument's sake. You know what my dad told me the secret was to marriage? Or at
What's
least
that?
saving money? Get in a fight with him right before the important dates so that way you don't have to buy him a gift.
Wow.
And then he also told me after I got married, he's like, Mijo, you shouldn't have got married. I'm like, Dad, thanks. That's a little bit too late. Oh, my dad's a dollar short. All right. So what else? So, like I was saying about nitro, just double check that they're not on any erectile dysfunction drugs. I remember a guy telling me, because I asked him, and he kind of whispers, takes me to the side a little bit. He's like, "Yeah, last night I took some. I think it was Cialis." He didn't want the wife to hear that because there's a bunch of guys around. It's like, I'm sure, ladies, you want to know, or you want the guys around there knowing that you and your hubby had some adult happy time last night. All right, what additional information would be helpful for the receiving hospital to know? As far as I could think of, is there really anything else that we didn't already talk about?
No.
Nope.
Okay. So other than reading what's in front of you, talk to me about an aneurysm. Oh, my stomach. Oh. And
So like a rupture you're talking about? Like
Like a balloon,
okay,
like when it pops.
bursts. So what's the danger of it?
Internal bleeding.
And
Fatal internal, well, isn't it fatal internal bleeding?
yeah, could be exsanguination.
yeah.
You can bleed out because they have to do emergency surgery to get in there and try to close off that wound. Do you remember when we were doing patient assessment? Claudia was there helping me. I remember when I was palpating her abdomen. What did I say we're looking for?
In, the chest cavity or the,
No, in the abdomen. Palpating the abdomen.
like if it has tenderness
What
or
else?
Any pain?
That's tenderness.
Oh yeah, tenderness. Yeah. Yeah.
tenderness. Or like it's like a bloating or like a hard rock.
Rigidity, distension.
Mm-hmm.
What else?
Or there's wouldn't it be like squishiness? Wouldn't that be tenderness too? Or
No.
it's, I know it's like it's when you kind of like start feeling like squishy or
Soft and supple.
yeah.
Remember I mentioned pulsatile mass?
Yeah.
That's what I was looking for. What is the pulsatile mass? It's a bulging of the artery, and it's pulsating because it's an artery. So it's bleeding out with every heartbeat. So it's a pulsating mass. We just call it a pulsatile mass. That's an indication of an aneurysm. Okay. And the reason being is it's more common in the abdominal region. And we call that a AAA, an abdominal aortic aneurysm. Mm-hmm. All right, as far as the dissection goes, remember I said there's layers?
Yeah. You want the layers?
So what happens, here's the blood flow normally, but now this got stretched and it's bleeding into here. And that's gonna start bulging up and go into the next layer, into here. To eventually it pushes so much that it starts leaking out. So that's the dissection where it's starting to go through the layers of the artery. All right. So there's the aortic rupture. Bad juju, right?
Yeah.
So there you go. So here's a picture of the dissection. There's a blood flow. There's the inner layer, the tunica intima, and then it ruptures. So now the blood is leaking into here. So that's going to start bulging up, and it's going to start. Whoops. It's going to start thinning this area here until it ruptures the outer wall. So not much you could do. Supportive care, maybe O2 and diesel therapy. Why don't you want to give aspirin?
When a patient has an aneurysm?
Yeah.
Because it'll dilate the vessels, which will cause more bleeding.
Nope. It doesn't vasodilate. It's not a vasodilator.
It's gonna constrict them.
No, it's not a vasoconstrictor either. It's an anticoagulant, isn't it? In other words, it prevents clotting.
Oh, that's right. It doesn't it thin the blood.
Yeah.
Oh, it's not really thin the blood. That's what they say. That call it for lay people. But no, it doesn't thin the blood. It prevents it from clotting. So why don't we give aspirin to an abdominal aneurysm or any type of aneurysm?
I guess it would stop the blood from trying to cover that hole, or the blood from leaking out.
Okay, what component of the blood? Okay,
The platelets.
But wouldn't it increase the more likely the rupture though?
Run the by me again.
Wouldn't it increase the aneurysm rupture more?
No, not the way I'm picturing it. That you're saying is it's going to make it bigger, the hole, and it's not going to do that. Basically, remember, blood is coming out. So what's the body going to do? Remember, blood is coming out. So what's the body going to do? It's going to cause it to take care of itself. So the platelets, as somebody was saying, are going to start clumping together, closing off that hole, right? Isn't that what we want?
Yeah.
Now, if we take aspirin, how is that hole going to develop? I'm sorry, not the hole. How's that clot going to develop?
It's not.
It's not, because aspirin's preventing it from clogging up that hole. Therefore, it's going to continue to bleed. It's not. It's going to continue to bleed. Okay. So no aspirin. All right. So I talked about females, non-classic. We've talked about what happens when you give too much oxygen, right?
Yeah.
Yes.
And that is
Free radicals.
the free radicals. And what do the free radicals do to the body?
They damage the tissue.
What part?
The heart.
More specific. The cell membrane. The free radicals weaken the cell membrane. Okay. What else? Man. We've talked about heart failure, right?
Yeah.
So for those that haven't answered, talk to me about heart failure. Waiting for an answer should take us to 12 o'clock.
It affects a large portion of the muscles.
Huh?
When are you talking about a heart failure or?
Yeah, with heart failure.
It results to a heart attack that affects a large portion of the muscles.
What muscles?
The ventricles.
Okay. So it can affect the ventricles, or actually does start in the ventricles. And so there's a failure. So what happens? So right now I'm pumping. Okay, this is my ventricle. But with age, with disease, with a heart attack, with something, what just happened to my pumping capability?
Which side of the ventricle are you talking about?
The left ventricle.
The left?
Weekend.
Yeah, it cannot pump blood out to the left ventricle effectively.
And so what occurs?
The reduced blood flow to the arteries, and then
Well, okay, the pulmonary artery. No, yeah, pulmonary arteries. And then what else?
the
Here's me pumping.
infusion to the blood.
I'm sorry, I was talking over you. What was that?
The reduced blood flow of the arteries, and then it starts perfusion.
They start what?
Perfusion.
Well, the perfusion is affected. Because remember, we have that backup of blood into the lungs.
Yeah.
So that's going to build up fluid in the lungs.
Yeah.
Okay. So if the person has left-sided CHF, left-sided congestive heart failure, where that ventricle is not working appropriately, not pumping appropriately, we get that back up into the lungs, and when we listen to the lungs, that's pulmonary edema. Okay. We listen to the lungs. Now, eventually, what's going to happen is the right side of the heart's going to start to fail. So tell me what's going to happen when you have right-sided failure. Tell me what's going to happen when you have right-sided failure.
The blood pressure begins to build up.
Well, you'll have that on the left side too. Well, you'll have that on the left side too.
Pulmonary hypertension.
Okay, but I'm not talking about that kind of stuff. What I'm talking about is if the right side of the heart's starting to fail, where's that blood backing up? Where's that blood backing up?
On the left hand side.
To the veins.
Want to be
What?
backing up towards gravity because it's the blood's not being pumped.
Okay, why is it backing up into gravity? Okay, why is it backing up into gravity?
Because the heart's not pumping the blood accurately.
To the brain.
That's where you get edema from in the feet or the ankles, correct?
Okay.
Feet or the ankles, correct?
Where else is the blood coming from that goes into the right side of the heart?
The lungs.
Right side of the heart. Right side of the heart.
The liver.
No. Or yeah, but it eventually meets up with the inferior vena cava, which is what dumps it off into the atrium, right atrium. What about above the heart? What about above the heart? What's that blood vessel called that dumps blood into the heart from the top part of the body?
Carotid.
No,
No.
that's an
The
artery, not a vein. Hmm?
aorta.
No, that's an artery.
Yeah. Sorry.
No, that's an artery.
Yeah. You said vein?
Which vein?
You said vein? Pulmonary.
No.
The subcapillary vein?
Huh?
The subcapillary vein?
Huh?
The
Which vein
subcapillary
brought blood to the heart from from the lower part of the body? From the lower part of the body. The inferior vena cava. So what's the blood vessel? What's the vein that brings blood into the heart from the upper part of the body? The superior vena cava. Okay. So the superior vena cava eventually comes up into the jugular vein. All right, jugular vein dumps into the superior vena cava into the right atrium. Okay. So that jugular vein, because it's backing up the superior vena cava, eventually into the jugular vein, what your patient's going to have is what we call JVD. Remember, we're looking at that at the patient assessment.
Yeah,
When we look at the neck, we're looking for JVD, jugular vein distension.
Yeah.
So that venous could be bulging out because of the buildup of the pressure as that blood is backing up, literally backing up. Okay. And then with gravity, with the inferior vena cava, the lowest point of the body due to gravity is the feet, the ankles. And so they'll have those swollen feet and ankles. We affectionately call those cankles. And that's when they have the cankles, when they have the JVD, that's right-sided CHF. Okay? Right-sided hip failure.
Is that treatable?
Yeah, they give them diuretics, medication that helps them pee, and also medication to maybe lower their blood pressure.
Okay.
Would water pills help that?
Well, that's what Lasix is. They call them water pills, but they're actually diuretics. More technically, it's a loop diuretic. It affects the loop of Henle, where it prevents the reabsorption of water, and it causes it to go down the ureters into the bladder. You pee it out. So that's what's happening in CHF. The ventricles are not as effective in pushing the blood out. So it backs up into the areas that it normally comes from. Okay. The other thing that happens is the ventricular muscle, the ventricular wall gets thicker because it's been pumping hard for a long time. And just like when you're pumping iron, your muscles get bigger. Well, the same thing with the heart. Unfortunately, your cardiac output decreases because the excess muscle took over space within the ventricle. Okay. And yes, Sequoia, you're talking about the liver. So you can have an enlarged liver, but the most obvious signs are the peripheral edema and the JVD. Okay. So think about that patient that has fluid in the lungs. And we covered this yesterday. How are they going to present?
For normal high blood pressure, rapid heart rate, shortness of breath, pale, cool, and clammy.
If you can't catch your breath, are you going to be anxious?
No.
Yes.
Yes.
Yeah.
Think about
Yeah.
it.
Yeah.
You can't catch your
Hyperventilating.
breath. We said yesterday, aren't you used to and like breathing?
Yeah.
Do you want to give it up anytime soon?
No.
No. So if you can't catch your breath, oh my gosh, I'm gonna die. No, I don't want to die.
They'll make them.
I'm gonna get married and divorced before I die. I'm gonna get married and divorced before I die.
They'll be restless.
Uh-huh. Again, it goes with that. I can't breathe. And now as you look at the picture, why I desire to sit upright. And now as you look at the picture, why I desire to sit upright.
Because they feel like, isn't it where they feel like they're drowning?
Yes, sir. Exactly. Exactly. Cankles. Exactly. Cankles. JVD. You see that jugular vein bulging out? See that jugular vein bulging out? So as far as us goes, with CHF position of comfort, which is sitting up, oxygen as before, 2 to 4 liters, depending on how they're setting. And if you're able to give CPAP, maybe give them CPAP. That pressure is going to be able to move some of the fluid out of the alveoli and be able to oxygenate the patient better. What's the danger of a high blood pressure? What's the danger of a high blood pressure? The danger is all that pressure building up. We're going to get pressure against arterial walls. So it is just like blowing up a balloon. You build up that pressure, you keep blowing and blowing and blowing and blowing, or your blood pressure keeps going up higher and higher and higher, and eventually what's going to happen to that blood vessel? Eventually what's going to happen to that blood vessel?
Rupture.
Yeah, pop. And then what happens? You bleed out. And then what happens? So that's why they tell, somebody will tell you if you're really, really upset, they'll be like, dude, chill out, you're going to stroke out. Because your blood pressure is going up and up and up to where it's putting more and more pressure against those arterial walls till they rupture. Okay. So we are worried about that. The other thing too is maintaining constant pressure, constant high blood pressure. It damages the kidneys and it could also cause damage to the brain. So blood pressure is not a good thing. That's why you got to watch your salt intake. That's exercise. You got to watch out for diet drinks because they help you retain, they contain salt, so they make you retain water. And you don't want to be retaining water. And that's why, like Sequoia was talking about the water pill, the diuretics, some women, especially models, will drink, or I'm sorry, not drink, will take Lasix to help them pee out that excess water weight. The bad thing is it can dehydrate you.
That's why also when people are trying to lose weight too, that they see the women that have water weight.
Uh-huh. And too much water can actually be harmful to or it can kill you.
Too much what?
Water.
Can be dangerous?
Can be fatal.
Oh.
There was a contest several years ago. I forget where it happened. It might have happened in San Diego. I forget if it was Super Bowl tickets or something, but they were giving out tickets for this big event. And so the competition was who could drink the most water. And this girl won, but unfortunately she diluted her blood so much, she actually went into a coma and died as a result.
Jeez.
Oh, damn.
Yep. All right, cardiac arrest. The heart stops, and you'll learn more about it with CPR. Oh, I talked to Michelle. I talked to Paul. She's gonna get the codes, but I was talking to Paul, and he's willing to come in and do the CPR class for you guys in groups, of course. But he was saying, because you guys have class Monday through Thursday, we could hold it on a Friday, Saturday, or Sunday. I would rather do it all in one day, but if you guys need to, I could see about him spreading it out. But kind of talk about it amongst yourselves, see what works for you guys, either a Friday, Saturday, or Sunday. Again, I would prefer one day, but if that's not possible for whatever reason, then we'll work on that. Okay. Hello?
Yeah, I heard you.
Yeah, sounds good.
Yes.
I don't know if it's a delay in my voice or what it is, but it's like, oh, is my speaker working? Is my mic working? But anyway, cardiac arrest, where the heart stops. And then you also have cardiopulmonary arrest, which is the heart stops and there's no breathing. Although usually if the heart stops, there's not going to be any breathing. And so there's no pumping action going on. It could be caused by a bunch of different things. A heart attack is one of those. An aneurysm, hydrogen ions, too acidic, tablets, poisons, a stroke, a thrombus, a clot, hypoxia, hypoglycemia. We call it the 6 H's and the 5 T's. So there's a lot of different things that can cause cardiac arrest. CPR is important. Okay.
The 6H.
Yeah, it's 6 H's and 5 T's. You don't need to know it though. I was just kind of putting it out there. If you really want to know, you could Google 6 H's and 5 T's. All right. Do you guys have any questions on nitro? I know we talked about it in pharmacology. We've talked about erectile dysfunction. We've talked about the blood pressure. Is there anything else that you guys don't know or want to know about nitro?
Not really. Not right now. Not that I can think.
Okay. I don't remember. Well, I didn't show you guys, but so here they're establishing the blood pressure to make sure it's safe to give it to her. They're getting the medical order. However, most of the time it's in your protocols. Okay. So you already have the medical order. It's a standing order. Okay. So they're doing what they call the 5 rights. The right patient, the right time, the right dose, the right drug, and the right date. In other words, you're going to write down the date that you gave it. I don't like the 5 rights because I just don't. I learned DICE. The drug, the integrity of the container, the clarity of the container, the concentration of the container, and the expiration date. Oh, that's what the right date is, the expiration date, that it's not expired. So she's checking to make sure it's okay to give her that medication. And then she takes one out into the cap. Normally you would give it to the patient, tell them to put it under their tongue. You could still put it under their tongue, but just make sure you document that you assisted the patient in self-administering the medication. Okay. If it's a spray, although I'd be a little bit closer because look at where that spray is going.
I don't know about mouth.
Yeah. So you want to get close to the tongue, underneath the tongue, have them raise up their tongue and just spray it underneath. Why do we give it under the tongue?
It's faster. It goes into your system faster.
Why?
The
Because
glands.
of all the veins we have underneath our
Yeah, it's a lot more vascular. Why don't we swallow the pill?
Because it takes longer.
What is that called? I think I covered it yesterday, didn't I?
Not sure. I don't remember.
Third pass metabolism. Yeah, it's very vascular and it's going to avoid the stomach and the liver. It's going to go straight into the bloodstream. All right, so you reassess in a few minutes. Make sure the blood pressure didn't drop too much. And also you got to reassess the blood pressure before any further doses. Okay. Now, with kids, heart problems are not caused by too many doubles animal style. Keto, I prefer it out over Whataburger. Kids, if they have heart issues, it's most likely congenital, meaning they were born with it. Now, the other thing about kids is that, remember, they lean on the respiratory drive?
Yes.
And so if there's a circulatory issue, they're going to lean on the respiratory drive. However, I think I mentioned this yesterday. If they're having respiratory issues, we don't want them to go into respiratory failure, because then it's going to be a tougher fight. Respiratory failure is going to lead to respiratory arrest. We don't want that, because now they're not breathing. And it's only a matter of time before they go into cardiac arrest. If a kid goes into cardiac arrest, then forget about it. It's going to be a very, very tough fight to try to get him back to where it's almost impossible. So you have to be very aggressive when it comes to kids and airway, because the number one cause of cardiac arrest amongst kids is respiratory issues. Okay? Respiratory issues. Old people, well, they do have, once we get older, we start having thickening of the arteries in the heart. So coronary artery disease is very common. But the muscle also becomes weaker, so more probability of them having some issues like CHF, like I said, coronary artery disease or CAD. The other thing is that the sense of pain is decreased, so they might not know they're having pain. They might have some discomfort, but they'll be poor historians as far as what they tell you is going on. And then there's also other chronic conditions such as diabetes. I talked about how diabetic patients are not going to feel a lot of stuff, and there is loss of elasticity. There's nerve damage. So, just remember that. Okay. Oh, one other thing with heart problems. So one of the things that's common for elderly people, including me, is falls.
False.
Now,
False. Like
yeah, like timber. Ow! I've fallen and I can't get up. So, whenever we have a geriatric patient, that means 65 and over. Whenever we have a geriatric patient, don't assume it was what we call a mechanical fall. In other words, that they tripped over their feet, they tripped over the rug. We always want to rule out a cardiac issue as to the cause of their fall. So ask them, were you feeling anything before you fell? Dizzy, lightheaded? Because it might have been something with the heart that caused them to maybe feel lightheaded and for them to fall. So always rule out a cardiac issue. It's just as simple as, did you feel dizzy or lightheaded prior to falling? because again, with the heart, it's not just the muscle we have to worry about when we get older, but it's also the electrical conduction. So they might have an issue with the electrical impulse that goes from the SA node throughout the rest of the heart. And because of an abnormal conduction pathway, they might have felt lightheaded because the heart is not contracting like it normally does, or like it used to. Okay. So really, it's the same for all of this. We already talked about all the assessment stuff, the secondary. We already did all this stuff. There's the pain. It's in your book. So different places where you could feel pain at. They gave her, so with Valeria and Sequoia, they transported Henry, taking in additional nitroglycerin, and they gave him some aspirin. Good, you guys talked about that. Pain level and vital signs were checked, 128/80. So really didn't change much. That's good. Pain went down to 4 on a 10, and Henry's a candidate for another dose of nitro. They advised the receiving hospital of his condition. They did a 12 lead, and the physician begins his assessment history. It is determined that Mr. Frey, or Henry, is in fact having an acute MI, and he's immediately prepared to receive fibrinolytic medications. Fibrinolytic are clot busters. So they're administered to help break up the clot that's in the coronary artery to reestablish blood flow. Okay. Questions?
No.
No.
Oh.
All right. So what did you think about cardiac emergencies?
It's a lot.
It is, but kind of like we mentioned yesterday, didn't we cover a lot of this information in the past?
Yeah.
Yeah.
Yeah. So the challenge becomes putting it all together. Putting it all together. And that was kind of what was here. And I got a lot of feedback yesterday about the scenarios, and I was told that they were good. It's a good thing to help review and learn this stuff. So with the scenario we did, we covered a lot of what was in here, like the assessment and the questions and stuff. We covered that. That's why I skimmed through it. But there's a reason we taught you patient assessment. Don't forget your assessment.
Yeah.
I want you guys, I don't want to call it homework because I don't want to have to give you a grade for it. But, kind of run scenarios in your head. So far, we've done respiratory emergencies and we've done cardiac emergencies. So kind of think of a scenario and just kind of start role playing it. Or make your girlfriend or boyfriend or wife or husband or sunshine or whatever, just sit there and they're your patient. And just kind of talk to them. Kids work well too, so.
Not all the time. There has to be like treats involved, like a dog. Okay.
You don't want kids, do you?
Nope.
But having dogs is just it's like the same.
Yeah, pretty much.
Mm-hmm. Although I've always said, and I do that with this dog, I don't beg. If you don't want to do something, that's all on you. I'm not going to keep begging. It's like I'll tell you once or twice, that's it. And that's what I did with her yesterday. I locked her out and she was being a little pest. Anyway.
Same with my English bulldog. So stubborn.
Probably the British part of him, not the male part. Because we men are not stubborn, right, guys?
No.
I saw you roll your eyes, Miss Sequoia. Did you guys see her roll her eyes?
It was not, and I don't know what you guys are talking about.
Mm-hmm. It's recorded. Remember that.
It was a glitch.
Okay. Yeah, you stick to that. I'm gonna stop recording right now.